عودا
تمام يا
حميدا.
دكتورة سارة.
أهلين هلا والله.
الحمد لله. حاطين اللينك على الجروب. تمام، وإن شاء الله
إن شاء
هم
الله.
في طريقهم للدخول إن
يلا
شاء الله.
حيا.
تحبي نبلش الحين؟
إيه يلا. If they are ready
طيب
نبلش إن شاء الله. بسم الله.
خلاص.
نبدي.
يلا حبيبتي، حياك الله، تفضلي.
الله يحييك. السلام عليكم. Good evening everyone. Sorry for this technical issue. ولكن ما أدري صراحة شنو صار. يعني أنا طلعت عشان أرد أدخل يطلع شيء أضبط، طلعت وما قدرت أدخل مرة ثانية. لكن الحمد لله إحنا اليوم our session is a little bit short. فأصلاً إحنا راح نخلص يعني كنا قبل الوقت، فإن شاء الله راح نخلص on time، وراح يكون في عندنا time for asking questions and answering them. again welcome again to our third session. إحنا الحين حالياً صح. Inshallah, our session today will be about endocrine emergencies. When we talk about endocrine emergencies, there are not, يعني ما في a lot of emergencies that we come encounter in primary care. They are a little bit limited, but they are important and they are serious. So one of these is the hypo and hyperglycemia. I think diabetes is a very common condition that we come encounter in our primary care settings, and it is يعني mainly our concern. احنا عادة نعالج الدايابيتيز. Usually hypo and hyperglycemia are the emergencies that we see a lot. And I'm sure during your career everyone has been in contact with patients with hypoglycemia or hyperglycemia. طبعا hypoglycemia يعني with the proper system in the clinic we are trying to avoid seeing the patient with hypoglycemia unless هو جاي من برا with hypoglycemia. يعني عادة أغلب المراكز حالياً، وأتمنى أن إذا هذا الشيء مو عندكم تقترحونه على مراكزكم، أن if the patient presented with hypoglycemia, so the patient will be in the the lab should be prepared for dealing with hypoglycemia. They should have like a sugary drink or dextrose or whatever available there, so they can give the patient right away, or juice, حتى simple juice. They can give the patient right away if they saw that his result or her result showing hypoglycemia readings. In that, the patient will come to you يعني bypassing the first aid. The first aid will be done by the lab and you will manage accordingly after that. فإذا هذا الشيء it's not applicable or it's not done in your clinic, and I would recommend that if you can recommend this to your seniors in the clinic or your head of clinic to activate the role of the lab in case of hypoglycemia when they check that the readings are low. In hyperglycemia, usually it's a little bit controversy, and we will see what are the controversial things that we come encounter in dealing with hyperglycemia. Adrenal crisis, it is something that we don't see a lot. It's not very common, but we have to be prepared for anything, and we have to be prepared for similar cases and have a high index of suspicion. The last case is thyroid emergency. Usually thyroid emergencies, I have seen once a thyrotoxic storm or thyroid storm where the patient was having hyperthyroidism and she was having all the symptoms of hyperthyroidism and she was not stable. And we will talk about the symptoms and signs and how to have initial management of similar cases. So the first topic is hypo and hyperglycemia. The main thing is to know what are the symptoms of hypo and hyperglycemia. I think all of you know that. So let's talk about the symptoms of hypoglycemia. The patient who may have loss of consciousness, so may come like unconscious. The patient may be conscious but dizzy, having delirium, having seizures. The patient may be having sweating, tremors, anxiety, doing abnormal behavior. I know one patient that when they have hypoglycemia, they become very angry and they are doing things like abnormal things. And يعني it's different than their normal behavior. And when they measure their blood sugar, they find that it is low, and the patient is having an hypoglycemia, and that's why the behavior changed. So behavioral changes is one of the things that you may see in hypoglycemia. I have heard about one patient that sometimes she's having hypoglycemia while she is sleeping. عادة شلون تعرف how do they know? Usually she wake up from sleep and beat her husband. تطق زوجها وهم نايمين، تصحى من النوم وتطقه. فلما ما أدري عاد هي تمثل ولا صدق، استغفر الله ما أبي أقول، بس يعني mainly When she did this, or whenever she is doing this, when they check their blood sugar, they found it is hypoglycemia. It's very severe hypoglycemia and reaching 2.5, 2. And right away, Maskin, the husband is giving her some sugary drink or something to raise her sugar, and she becomes calm after a while. So you never know what are the presentation. So if you are seeing like abnormal behavior in a diabetic patient who is like having recurrent hypos, try to check his blood sugar or her blood sugar, because it may be the sign that, or the symptom that the patient is presenting with. Symptoms of hyperglycemia, the patient may present with symptoms of diabetes, polyuria, polydipsia, dehydration. If diabetic ketoacidosis is suspected, the patient will have abdominal pain, nausea and vomiting, Kussmaul respiration, which is deep hyperventilation, acetone smelling breath. All of these are symptoms of hyperglycemia. Also, sometimes the patient may come with coma if it is severe hyperglycemia or in diabetic ketoacidosis or hyperosmolar state. Signs and examination finding usually are, we can, I know all of you also has detected it and know it. What are the causes of hypoglycemia and hyperglycemia? We should keep it in mind. So, common causes of hypoglycemia is that the patient took his medication, whether a sulfonylurea or insulin injection, and they did not take a proper oral intake, or they delayed their meal, or for example, either they did not take meal or they delayed their meal. In this situation, they may present. This is the most common reason for the hypoglycemia. We will talk about few causes of hypoglycemia or what we have to suspect. Also, patients who are diabetic and alcohol consumers, they may present with hypoglycemia. Also, in pediatrics age group or adolescents, we may suspect that the patient is like attention seeking, taking the insulin injection and not taking food to develop hypoglycemia, and for example, seek attention from his parents, or avoid going to school, for example, now since the school came back. So just have a high index of suspicion of the reasons that are not regular ones. Also, if the patient is having a caregiver, for example, an elderly who's with a maid or a caregiver, whoever the caregiver, even if a son, and they are doing domestic abuse for this elderly patient, unfortunately, which is something, مع الأسف it's there. So the patient may be given higher doses of insulin to develop hypoglycemia, or they are giving the injections and they are not giving food. So always, if you are seeing like a peculiar history, or it's not so straightforward history, or there is something, like you don't feel comfortable, try to dig more in the history, try to detect those reasons or those things, go into the psychosocial history and try to find how's the situation at home, how's this child or this adolescent or this adult or this elderly person is like the home dynamics in their home, who's the caregiver, and all of these things. And it may help you in the diagnosis and to prevent further attacks. Okay, so this is a diagram showing how to deal with hypoglycemia in adults. What will happen? I think in adults and pediatrics are the same. The dose is a little bit different. So how we are going to treat? First of all, I want to say that the patient is having hypoglycemia. Usually when the blood sugar is below 3.9 with hypoglycemic symptoms. So in this situation, we have to check the conscious level. If the patient is unconscious, or let's say conscious, let's go with the conscious patient. So if the patient is conscious, we see, is the patient able to take food or not? So if the patient is oriented and able to swallow, not drowsy, not like sleepy, it's not about to faint. So in this situation, we can right away give a fast-acting oral glucose, 15 grams, followed by a long-acting carbohydrates. So we can give him a meal, we can give him a biscuit, a bread, or anything, or a sandwich that will have a complex carbohydrates in it. So this, if the patient can tolerate oral. If the patient cannot tolerate oral for any reason, he's drowsy, he's dizzy, he's like having about to faint or to lose consciousness, or he cannot swallow, he's not like oriented with you, so unable to cooperate, then we can give IM or subcutaneous glucagon 1 milligram. Just keep in mind, as I think we mentioned that before, whenever we give a glucagon, we have to keep the patient in the lateral position or in the recovery position. And why is that? because we all know that by now that glucagon may induce nausea and vomiting, or may cause nausea and vomiting, and we don't want this patient who is about to faint or he's unconscious to have vomiting while he's dying supine and causes aspiration. So always when you give glucagon, just keep the patient in lateral position, especially if the patient is not so oriented. So this is if the patient is conscious, as simple as that. Can take food, give him sugary drink or some oral glucose, then a complex carbohydrates. If the patient cannot take oral, you will give IM or subcutaneous glucagon 1 milligram. And then we will see how to follow up the patient. If the patient is unconscious, we have to call ambulance, we have to check the ABCDE, and we have to start treatment right away by either given IM or subcutaneous glucagon 1 milligram, and also to keep the patient lateral position. Or if we have an IV access, we can give the IV 50 milligram, 50% dextrose. So then we have to, whether we give the patient the oral dextrose, the oral medication, the IM or sub-Q, or the IV. Then we have to remeasure the blood sugar after 15 minutes and repeat the treatment until the blood sugar reaches above 4 millimole per liter. There's one point here that is important, and it's always mentioned in guidelines. If the patient is in sulfonylurea, especially the old sulfonylureas, Dawanil, we don't use it anymore now, Aclashirhin, Dimicron, Amaril, the new ones, the new generation of the sulfonylurea, but the old ones, كل sulfonylurea are long-acting, they are taken once only. So that's why when we take, when the patient is on sulfonylurea and he is having hypoglycemia due to the sulfonylurea, usually this patient needs to be observed for 24 hours because he's prone to develop another hypoglycemic attack. So if there is no proper observation at home, there is no, مثلا the patient is an elderly, the patient مثلا educational level is a barrier of explaining to the patient that you have to eat properly and to measure the blood sugar at home and so on. In this situation, it's better, and the safest thing and the recommended thing is to refer the patient to the emergency room. So they will keep him under observation for a few hours, mainly 24 hours. And I have seen a lot of patients that they are only on sulfonylurea with the glucophage, and they had an attack of hypoglycemia, although they did not lose consciousness, but they were like semi-conscious, and they've been referred to the emergency room. They were kept there for 24 hours observation because they were elderly and they are afraid that they will have another attack. So the safest thing to do is to refer the patient for observation in the emergency room to avoid, or if the patient will have another hypoglycemic attack, he will be under observation. Okay. So this is another photo from the, I think you all have the emergency manual that is from the الإدارة المركزية, Central Directorate. It contains a lot of good information, in fact. One of them is this diagram that I liked, which is categorizing the patient again into conscious or unconscious patient. And if the patient is conscious, they are giving you the other options of treatment that you can give. So the main thing is to give 50 to 20 grams of fast-acting simple carbohydrates to be ingested. Equivalent, or something that equivalent to this 50 to 20 grams is a quarter to 1 cup of juice, 120 ml juice, 3 to 4 glucose tablets, or tablespoon of honey. All of these are equivalent to 15 to 20 grams. We can repeat the test after 10 to 15 minutes, as mentioned. If it's still low, repeat the above step. So again, we will give another sugary product. If normal, give patient complex carbohydrate like biscuits, bread, toast, or sandwich, or a meal, and send him home. If the patient is unconscious, we can, as we said, give either the glucagon. If we don't have an IV access, we will go right away to IM or sub-Q glucagon. The recommended dose is, as we mentioned, 1 mg. In adult, we can use up 0.5 mg. So they have half dose. Repeat in 15 minutes. If no response, the children, after the repetition, will be 0.03 mg per kg. The maximum dose is 1 milligram. If glucagon is not available, or we have an IV access, or we had the time to insert an IV access or IV line, we can give a 75 to 80 ml of 20% dextrose IV, or 150 to 160 ml of 10% dextrose In children, 5 ml per kg of 10% dextrose IV given slowly. Other treatment will be based on etiology. So I think this elaboration is more elaboration on how we can give the dextrose and the glucagon and the sugary products. This is regarding hypoglycemia. Of course, after finishing treatment with hypoglycemia, we have to dig more in the history, again, as I mentioned before, to look if there is any underlying cause of this hypoglycemia. Is it repeated or the first time? If it is repeated, what are the reasons for this repeated hypoglycemic attacks? Do we need to adjust this patient's medication, or we can only adjust his dietary habits? For example, not to delay meals, to have, for example, snacks in between meals. All of these are valid advice that we can give to the patient. So always after managing a patient with hypoglycemia, you have to take proper history to manage accordingly, whether the dosage of the medication or the dietary advice. Or of course, if there is underlying child abuse, domestic abuse, or anything that is other reasons we have, or alcohol consumption, for example, or any medication that may cause hypoglycemia, we have to consider treating this underlying cause. Okay, the other thing, or the other topic that we will talk about, is hyperglycemia. So in hyperglycemia, which means, according to guidelines, that it is if the blood sugar is above 13.9 millimole per liter. طبعا احنا, as we all know, hyperglycemia fasting, I can see that this patient is having hyperglycemia if his blood sugar above 7. صح ولا لا؟ إن هذه diabetes. These are diabetes reading. This is hyperglycemia. If the patient is having postprandial above 10, I can say this is hyperglycemia. But when we have to say this is a hyperglycemic emergency, that we have to check the urine ketone for it. This is done when the blood sugar is above 13.9. I tried to find many references to look for the exact number, and this is the number that I get from the ADA and from some few other references. So it is 13.9 millimole per liter is the time where we have to check for urine ketones. So if the patient is presented with a blood sugar of 13.9 and the urine ketone is checked, then we will categorize the patient according to the finding of the urine ketone. If the urine ketone is negative, well and good. We are happy now. We are a little bit not so in hurry, especially if the blood sugar is not so high. So we will give an IV fluid, as that we will mention now in a while, and then we'll just adjust or start medications, and we may refer urgently to the diabetes clinic for follow-up. تعطوني بس دقيقة لو سمحت. Okay, so this is regarding if the ketone is negative. So we will give IV fluid now. We will adjust or start medication, and we will refer this patient to the clinic for follow-up. If the urine dipstick is positive for ketones, and the patient whether is having symptoms of diabetic ketoacidosis, then this is diabetic ketoacidosis. We have to refer the patient by ambulance. Better by ambulance, after checking the ABCD, and while waiting for the ambulance to come, you should start IV fluids. The recommended IV fluid is 1 liter of 0.9 saline over 30 minutes to 1 hour. We can repeat up to 3 times if needed, and then 500 ml per hour for the next 2 to 3 hours, which usually will be done in the emergency room. In pediatrics, which is something common that we may see, diabetic ketoacidosis in pediatrics in the clinic, and I have seen a case maybe 2 weeks back in the on-call. She was 13 years old, presented with high blood sugar. She was non-diabetic type 1, and she presented with positive ketones. So we gave her fluids. We inserted an IV line. Fortunately, the sister was, the nurse was competent to do so, and we gave her a 10 ml per kg of normal saline, and then we referred her to the hospital. So this is in case of positive or negative. So there is a situation where the ketones will be negative, but the blood sugar will be so high. And this I have seen 2 days ago. The sugar was 35. The lab told us that the patient did the blood test, regular blood test, and he was diabetic, not on proper follow-up. And when we checked his blood sugar, it was 35. So this case, we can call the hyperosmolar or hyperglycemic hyperosmolar state. The patient is prone to complications. He's prone to coma in this situation. So this is an emergency. We should not give medication and send him home. We should refer this patient to the emergency room by ambulance, also after checking ABCD and stabilizing the patient, and start IV fluid with the same dose that have been mentioned for diabetic ketoacidosis. Of course, in the emergency room, they will start giving insulin after checking electrolytes. Of course, the patient will be sent again back to us for follow-up and for starting medication or adjusting his medications. So there are some dilemma in hyperglycemia. And the most common question that I have been always asked, and I was asking myself about it, and then whenever I give this session, everyone will ask me about this question, so I decided to put it right away. Should you give insulin? Should we give insulin in hyperglycemia? Whether if it is diabetic ketoacidosis or not. So the answer is, we have two situations, just to keep it in mind. If it is diabetic ketoacidosis, we should not give insulin in the emergency, in the clinic. We should refer the patient, and they will check the potassium level, and accordingly, they will give insulin after checking potassium level. Because there is a risk of hypokalemia. If the patient is newly diagnosed, he was not on insulin before, he was not on any medication before, we say this patient is insulin naive, he has no, we don't know how sensitive he is to insulin, we should not give insulin because it may cause complications if he started and we don't know how sensitive he is to insulin, and he may develop hypoglycemia right away or fast. So in this situation also, it is better to avoid giving insulin. So the dilemma always happens in between those people. If the patient is non-diabetic, usually the newly diagnosed, we have very high sugar, usually almost all doctors will refer if they're very high sugar. Either the patient is non-diabetic ketoacidosis, أنا ميوسد يا جماعة من متى؟ وين آخر شيء خلينا نشوف وين. استغفر الله اليوم.
دكتورة بس
لا دقيقة واحدة بس، ثانية واحدة بس. كنت معانا؟ لا.
الحمد لله.
تفضل.
Okay. So وين وصلنا؟ فاحنا قلنا so do we give insulin or not? Usually there will be no problem if the patient having diabetic ketoacidosis. Usually everyone will refer, ما حد راح يختلف. Nobody will there will be no conflict on referring the patient in diabetic ketoacidosis. Also, if the patient is insulin, this is the first diagnosis, and the blood sugar is very high, also most of the doctors will take the decision of referral. Usually the problem will occur in between those. More diabetic ketoacidosis, acetone is negative, it's not so high, not above 13.3, which increase.
مايك
بروحه ترى قاعد يصير لي ميوت. زين. فهذين الحالتين ما عندنا مشكلة. المشكلة اللي بالنص. This patient is not having diabetic ketoacidosis, he is non-diabetic, his blood sugar usually is uncontrolled, يجينا بقراءات 18, 19, 20, the acetone is negative. So are we going to give insulin or not? The proper and the best answer and the recommended answer is not to give insulin. So أنا الحين شغالة 10 سنوات في primary care. I have never given insulin to a patient with hyperglycemia. Usually what I do in those patients اللي جايين high blood sugar and they have negative acetone, usually I give them IV fluids. Normal saline, 2 pints, 1 liter, and I remeasure it again. Usually 90% of the time it will reduce. It will be reduced. إذا كان 20 19 راح يوصل 15 12 ممكن يوصل هالكثر. I adjust medication, give very close follow-up second day or the day after, and I will send the patient home إذا كان symptom free. If the patient is having symptoms and his blood sugar is 20, 21, 19, I send the patient to emergency room. I give IV fluid and send him to an emergency room. And usually it happens a lot to me. تصير معي في type 1 diabetic. I check acetone, it's negative. And the blood sugar is high. They are having symptoms. I refer them to emergency room. They are keeping them almost يقعدون لما يرجعون لي بعدين الفيدباك. And they kept us in the emergency room for like almost 12 hours. And they were giving us a lot of fluids until our blood sugar controlled and became normal. Then they sent us back home. So the proper and best thing to do is not to give insulin when you don't have the potassium level. So this is the safest thing to do for your patient. So ليش نحط نفسنا at risk ونحط البيشنت at risk ان انا اعطي انسولين. and although كلنا طبعا ادري الجمله المعروفه دكتوره 6 units ايش راح تسوي؟ صح, it may not do anything but it may do something. So خلينا نحط قاعده عامه. diabetic ketoacidosis, give IV fluids, refer. First time newly diagnosed high sugar, give IV fluid and refer. In between, and it is like patient is symptomatic, refer. Patient is not symptomatic, give IV fluids, wait, check blood sugar again, improved, send home after adjusting medication and give close follow-up. If not improved, you have the decision to send the patient home or give him treatment. And also the patient, usually هذيل المرضى عادة هم متعودين دائما يكون مرتفع عندهم. فهم جايين يمكن not for that reason, جايين for something else, and we found that it is very high. They were not expecting it to be referred, not expecting لأنهم دائما عندهم عالي. فهذيل priority to be referred to the clinic for adjustment of their medication rather than refer them to the emergency room. I hope that you can understand the difference now. You can like take your decision now. So are IV fluid enough? The first step in the treatment of DKA and HHS is infusion of isotonic saline to expand extracellular volume and stabilize cardiovascular status. So yes, it is important. It is the first step in those two serious situations. So it is beneficial even in the other situations. Do you have to refer? If it is diabetic ketoacidosis, yes. If it is hyperosmolar hyperglycemia, yes. Hyperglycemic state, yes. If it is the first time, yes. If it is not relieved by IV fluids and the symptoms persist, yes. So those are the 4 situations where it is encouraged and advised to refer the patient to the emergency room. There are special situations, as we said, if the patient is on sulfonylurea and having hypoglycemia, again, it's better to keep the patient under observation. If the patient is a child, it's a pediatrics having recurrent hypoglycemia, just keep an high index of suspicion of child abuse, suicidal attempts, attention seeking. Precipitant of HHS. What are the precipitants of HHS? Alcohol consumption, cocaine, antiarrhythmic medications, SGLT2, phenytoin, beta blockers, thiazide diuretics, loop diuretics, and statins. So the patient is having diabetes and he's on one of these medications coming with very high blood sugar, above 33.3. This is HHS, and the reason could be one of these. So we have to rule them out in the history. So this is regarding hypo and hyperglycemia. I hope it's clear. And if you have any question, we will inshallah answer it at the end of the session. The third topic that we will talk about is hypoadrenal Addisonian crisis. So what are the symptoms that the patient will present to us with? Nausea, vomiting, hypotension, and shock. Many things can cause those symptoms. So شنو اللي يخلينا we think of and this is a hypoadrenal Addisonian crisis? There are risk factors. Patient is on steroids. Patient on long-term steroid treatment or replacement. If the steroids are stopped suddenly, then and the patient came with nausea and vomiting, hypotension and shock, we may think of the Addisonian crisis. During an intercurrent illness, again, the patient is on a steroid and he's having upper respiratory tract infection, for example, and with the upper respiratory coming with like hypotension, shock, nausea and vomiting, just keep a high index of suspicion. This is due to the Addisonian crisis. And we will see what we are going to do. As a presenting feature of congenital adrenal hyperplasia, so could be the first time, and Addison's disease if the patient is known to have Addison's disease. So what is the management? We have to stabilize the patient. We will go with A, B, C, D, E, call ambulance because the patient hypotensive. Okay, the patient getting hypotensive and in shock. This is an emergency. We'll go to the emergency room, put large bore cannulas inside the veins. give him IV fluids, check airway, breathing, circulation, disabilities, and exposure if needed, and call ambulance because this patient should be transferred to emergency room, and give IM or IV hydrocortisone, which is available, while awaiting transfer. In adults, the dose will be 100 milligram up to 12 years, and in children, from 1 month to 12 years, the dose is 2 to 4 milligram per kg. So شنو راح يصير لو بنفكر بالسيناريو؟ المريض راح يجينا عندنا بالسيستم مثلا اذا عنده اديسون جايب whatever symptoms of upper rasp for example، بعدين جاينا ب symptoms that doesn't go with upper rasp، يعني جاينا ب nausea or vomiting، he's confused, he's having his very low blood sugar, he looks like he's hemodynamically unstable, although it's only a simple upper respiratory tract infection. But then we will ask about the steroid injection. Does the patient double the dose with this intercurrent illness? If yes, then we should think of any other cause. If no, then there is mostly this is Addisonian crisis. With intercurrent illness, the dose should be doubled. And usually the patients on steroid, long-term steroid, this is the advice that is provided for them in the secondary care when they prescribe the steroids for them. So there are things we can do to prevent similar attack. We have to warn all patients taking long-term steroid not to stop their steroids abruptly, and to tell any doctor treating them about their condition. Advise patients to carry a steroid card or Addison's disease self-help group emergency card, and wear a medic alert bracelet or similar or anything يعني similar. ممكن يكون شيء ميدالية ينحط بسيارة يعني بالمفتاح سيارة أو whatever يعني is available in case of emergency. Double the dose of a steroid prior to dental treatment or intercurrent illness like upper respiratory tract infection. In vomiting, replace oral steroid with IM hydrocortisone. يعني مريض عنده vomiting for whatever reason, we have to substitute the oral steroid with an IM hydrocortisone. In this situation, we are trying to avoid having Addisonian crisis. لكن بالنسبة لنا كemergency راح يجينا المريض hypotensive، فهو whatever was the reason احنا راح نعامله as انه عنده شوك، او راح يجينا بشوك نحط له كانيولا، نحط له fluids، we'll transfer the patient، ناخذ هيستوري منه على ما نحوله. واذا كان عرفنا انه على ستيرويد وقفه abruptly or he's an intercurrent illness, we can give a hydrocortisone injection as we mentioned with the proper dosage. Prevention. The third topic we will talk about, and this is the last slide, it is the thyroid storm. So thyroid storm, it happens when the patient is having non-hyperthyroidism or having hyperthyroidism, and the thyroid function will be very high. So in this situation, the patient will present with thyroid storm. What are the symptoms and signs of thyroid storm? Cardiovascular symptoms like tachycardia to rates that can exceed 140 beats per minute, congestive heart failure, hypotension, cardiac arrhythmias, and death from cardiovascular collapse. So it is a serious situation. Hyperpyrexia, the temperature will be between 40 and 41. Agitation, anxiety, delirium, psychosis, stubborn patient or coma. In one serious study, any altered mentation was the only clinical finding that distinguished storm from compensated hyperthyroidism. يعني الhyperthyroidism may be present very severe، بس عشان نعرف if this is hyperthyroidism or this is a storm, this is only hyperthyroidism, we have to refer the patient ونعطيه اندرال مثلا ونوديه البيت، أو إن هذه storm إنه يكون عنده altered mentation، يعني عنده delirium، عنده agitation، عنده psychosis، هذا stubborn، coma، هذه الأشياء كلها it means that there is a thyroid storm rather than only hyperthyroidism. In another series, it was statistically associated with mortality حتى. Severe nausea, vomiting, diarrhea, abdominal pain, or hepatic failure with jaundice may develop with the thyroid storm. What are the physical examination findings? We will find a goiter, we will find ophthalmopathies in the presence of Graves' disease, we will find lead lag, hand tremors, and warm and moist skin. I have seen one patient who presented with to me with she was having like a little bit of confusion. She was known to have hyperthyroidism. She's a Filipino lady. She went to her country, and in her country, she didn't take any of her medications. When she came back to us, she was on carbamazole. When she came back to Kuwait, again, she was not on any medication. Her symptoms deteriorated. She was a maid working at home. The sponsor realized that she's having abnormal behavior. She's not normal. So she brought her to the clinic. When I examined her, I found literally all the symptoms of hyperthyroidism and all the signs were there. Every sign, it's like a textbook. كل the signs and symptoms of hyperthyroidism was there. One of the things that was very يعني very مش هقول لكم يعني كان يعني مو it wasn't a surprise for me بس كان very obvious زين. كانت متسندة على الكرسي وقاعد أسوي لها الإكزامينيشن. I was auscultating her chest to see if there is any bruit in the neck and if there is any AF or something. So I was auscultating the chest, and from the palpitation that she was having, she was going into the back and front. تخيلوا من البالبيتيشن كذي دب مع نبض القلب كانت تروح وترجع من كثر ما البالبيتيشن كانت very severe. فيا you can يعني this patient was of course supposed to be referred to the emergency room where they will treat her with beta blockers or something to relieve her symptoms, and maybe they will do admission for her and treat her properly in the hospital. And thank you very much.
Thank you دكتور سارة. Thank you. زي ما عودتينا والله يعني مشكورة يعطيك العافية. ما قصرتي. Informative, professional, to the point والله related to our practice. Thank you.
Thank you very much. أنا بس عندي شغلة ودي أقولها related to emergency. ما أدري إذا لاحظتوا في أغلب مو أغلب المراكز، كل المراكز حالياً الإمرجنسي صار لها ايكون فوق باللون الأحمر emergency.
صحيح.
إيه فإحنا الحين إذا سوينا تحويل راح ترى عادة إذا جاتكم حالة و you are suspecting this is an emergency بس تطقون على emergency كل السيمبتومز والساينز والاكزامينيشن كلها راح تتحول حق emergency symptoms and signs and examination findings. يعني ما راح يكون في الاشياء مالت الكولد كيسز. احنا طبعا خفنا ان الناس ما تستوعب وما تحط الامرجنسي لما انتهى امرجنسي من كثر العجله وكذي، فصار شنو انه لما اخر شيء when you want to print the referral for the emergency you will have a pop-up of the الصفحه اللي تحطون فيها الامرجنسي متى كولد ومتى يت والاوتكم مال الامرجنسي. فاتمنى يعني اذا جاتكم حاله emergency تحطون هذا تستخدمون الفايندينجز اللي موجوده. It will help us again and it is beneficial وإن شاء الله راح تنفعنا وايد في الداتا و improvement of emergencies إن شاء الله in the future. فبس كنت حابة بس أذكركم بهذه عشان يعني تحطونها في بالكم تستخدمونها إن شاء الله. و I'm ready to answer any of your questions.
دكتورة سارة عندي سؤال سريع.
تفضل.
الشجر إذا أعطيناه اي في بوش سريع في مشكلة؟
إذا أعطيناه شنو؟
اي في بوش سريع. هو سريع.
شنو اي في فلويدز؟
اي مثلا اي في ديكستروز 50 بوش في مشكلة؟
لا.
بوش سريع.
نو.
عاد.
يعني
قصدي الكوركشن السريع تبع الشجر بيعمل مثلا مشكلة ولا عاد؟
نو اصلا احنا مو قاعد نعطي اي ام جلوكاجون، هذا اسرع اصلا. فنو there will be no problem ان شاء الله.
تمام.
اوكي. في اي سؤال؟
السلام عليكم دكتورة سارة. معلش عندي سؤال. في حالات شفتها كانت بتيجي بنات سن صغير يعني في العشرينات او تحت ال20، البنت بيجي لها اتاكس من الهايبوغلايسيميا وهي يعني ولا بتاخد ادويه سكر ولا هي دايابيتك اساسا. فدي يعني ايه ممكن تكون الاسباب؟ انا بصراحه يعني حولتها الاندوكراينولوجي ونصحتها بس انها تاخد وجبات صغيره، يعني ما تصومش فترات طويله او ما تاخدش وجبات على فترات متباعده. بس يعني ايه ممكن تكون الاسباب يعني لو هي ما بتاخدش اي ميديكيشن او كده؟
اول شيء دكتوره الهايبوغلايسيميا دوكيومنتد، يعني انت تشيكينها عندك ولا هي تقول لك المريضه؟
لا دوكيومنتد وفي كمان كانت بسيمتومز، يعني بس مش ان البلاد شوجر مثلا تحت 4، لا كمان يعني سيمتوماتيك.
شوفي انا يعني one of the reasons طبعا I don't think ان this is something dietary، لان non diabetic patient even if سوينا starvation مده طويله the body will compensate، يعني ما راح يصير عندنا hypoglycemia that is سيمتوماتيك. يعني انا مثلا لو اقعد مده طويله عن وقت اكلي ما اكل، احس شويه رجفه. يعني ما ادري، ما عمري تشيكت الشوجر شلون، بس اروح على طول اكل، بس ادري لاني ماخذه يعني long time of starvation. بس يوجوالي هذول اللي تحكين عنهم تكون ماكله وهم فيها الهايبوغلايسيميا، صح؟
صح.
اي طبعا. شوفي، اول شيء انا ممكن افكر فيه اذا مسويه بارياتريك سيرجري، لان البارياتريك سيرجري يصير معاهم something called dumping، يصير عندهم هايبوغلايسيميا after a meal. So this is one reason, one thing. I would think of insulinoma or like malignancy أو يعني a tumor that's producing insulin. So I will check insulin for them, insulin level. معاي دكتورة؟
معاكي.
For now I think يعني هذول أول شيء راح يطلعون على بالي. If there's no reason, I would refer for further investigations. I think we should all read about what are the causes of hypoglycemia in non-diabetic patient. الحين حاليا هذول الشيئين الديفرنشال اللي طروا على بالي، يعني اقدر اقرا لك زياده وان شاء الله احنا نفيد بعض. يعني يا ريت انت تقرين وانا اقرا او الكل يقرا يعني، ونفيد بعض المره الجايه ان شاء الله.
ان شاء الله. شكرا يا دكتوره سارة.
You are right in this patient deserves to be referred. بس يعني حلو هم احنا نكون عندنا شويه differential و we rule it out by history على الاقل او some investigations.
طيب دكتورة سارة، بخصوص الثايرويد ستون مش هنعمل لها حاجة في المستوصف؟
راح تحطينها بالامرجنسي روم، تحطين لها اي في لاينز وتطرشينها المستشفى.
تمام، شكرا.
شنو تبين تسوي لها دكتورة بسمة؟ تعطينها يعني بيتا بلوكر؟ ها دكتورة؟
والله هو الوصف اللي حضرتك بتقوليه يعني التاكي كارديا كانت فظيعة يعني، فأصلا الإسعاف عما بيجي بيبقى ممكن ساعات بتأخر نص ساعة بتاع، فممكن.
صح كلام. إيه إذا كانت هي جاية بAF مثلا، هذه she will be managed as an AF بالأريثمياز، المانجمنت مال الأريثمياز. أما إذا جاية بس بساينس تاكيكارديا severe tachycardia which is sinus، وهذه المريضة اللي أنا جتني كانت sinus tachycardia. This patient I will not give her anything صراحة. أنا I referred her يعني very fast to the emergency room. في أي سؤال بعد؟
السلام عليكم دكتور. سؤالي من الهايبرجلايسيميا يا دكتور، هندي الاي في فلويدز او النورمال سلاين يعني تو هاو ماتش او ايه الاكستنت اللي اقدر عنده اوقف؟ اوكي خلاص مش هندي نورمال سلاين.
يعني شنو الرقم قصدك اللي بعدها يكون نورمال، او يعني قصدي بعدها توقفين هذا ولا كم مره؟
اوكي
اوكي
مثلا
ما في
الكيس اللي حضرتك عليها البنت يعني مثلا 13 سنه.
Yes I'm not expecting. طبعا البنت اللي عمرها 13 سنه كان عندها diabetic ketoacidosis، فهذه انا اعطيتها الاي فلويدز وحولتها على طول. They will manage her in the emergency room. They will start her on diabetic ketoacidosis protocol ويعالجونها هناك غير يعني لها special treatment. اما اذا جاينا المرضى العاديين اللي قلنا اللي بالنص هذيل اللي مو first time ولا اللي diabetic ketoacidosis ولا 33.3 and above, but this is not a hyperosmolar state where we have to refer. اللي بالنص بو هذيل ابو 20 بو 19 بو 18 اللي diabetic من زمان وعلى medications وياي بدون symptoms و incidental finding of hyperglycemia، هذيل يجوا يعطيهم 1 لتر. انا I can repeat بس انا عاده اعطيهم 1 لتر. هاي تشيك نزل شويه على طول I start taking history, adjust medication أنا وأشوفهم very soon يعني ثاني يوم أو the day after giving proper advice. فما في رقم محدد، المهم إنه يصير في response. يعني إنه إذا كان symptoms راحت الsymptoms تحسنت، إذا كان ما في symptoms يعني المريض بدون symptoms أصلاً و incidental finding على الأقل نزل شوية by 2-3 millimole per liter وأعطيه على طول. يعني هذا ما راح تكون the only step. Next step خلاص adjust medication. The next step follow up very very soon.
تمام دكتورة شكرا.
دكتورة السلام عليكم.
عليكم السلام.
دكتورة لو دايابيتك بيشنت وجاي بمايلد سيمتومز يعني بوليوريا بوليديبسي بس مفيش ديهايدريشن ولا ابدومينال بين ولا فوميتنج، مفيش سيفير سيمتومز يعني، وانا ما عنديش كيتون تيست في المستوصف حتى عند النيرس مفيش، مثلا فترة العصر ما عنديش لاب ومفيش سيستر ما عندهمش التست والبلاد شوجر بتاعه عالي. ايه
ما عندهم دبستيك؟
ما عندهم والله انا جربت كده مستوصف وخفرات وكده مفيش.
زين.
لو انا يعني انا just suspecting ممكن تكون دي كي او لا، يعني هو عنده high blood sugar، ده المفروض ان انا اعمل له referral على طول ولا يعني الابروتش هيكون؟
اذا high blood sugar and you are suspecting يعني ما تدرين، ما عندك الفاسيلتي to test for ketones and to rule it out، انا the safest thing to do for the patient is to refer.
تمام. سؤال تاني دكتورة، بالنسبة للدكتورة علاء كانت بتتكلم في الهايبوجلايسيميا، بنشوفها أحيانا كتير في اليونج ايج. أنا شفت فيميل يونج ايج جاب شوية ديزنس مايلد، هي مش عاملة برياتريك سيرجري ولا حاجة وماهيش ريكارنت اتاكس بالنسبة لها، بس لما قست البلاد شوجر كان 3.9. أنا عطيتها شوجر دكتورة يعني تقريبا ريميجر بلاد شوجر افتر يعني 15 minutes كان 1.7. 1.7
نزل زياده.
هل ده رياكتيف يعني ولا ده ايه؟ ده رياكتيف هايبو ولا ده يعني هي مجرد يعني اخدت بس الجوس وافتر 15 minutes وانا واقفه يعني صار 1.7
والله
طبعا. وهي
يعني
دكتوره
هذول اللي انا
مفيش اي اكزربيشن للسيمتومز عندي ولا اي حاجه، ويعني كونشاس وكل شيء تمام، بس كان شويه مايلد ديزنس. بس احنا لما عملنا ريت تشيك تاني افتر 15 minutes اجين صار نورمال، يعني هو صار نورمال خلاص بروح، ما حطيناش اي في ولا اي حاجه، بس يعني رد نورمال فوق الاربعه.
سيم ماشين اللي استخدمتوها في المره الثانيه اللي صار فيها 1 point something.
شنو؟
سيم ماشين سيم جلوكوميتر
نفس السيستر، نفس المكان، هي البيشنت موجوده في السيستر روم في النيرسينج روم. انا مش عارفه هل انا بصراحه ما شفت الرقم اتخضيت، بس هي البيشنت قدامي مفيش فيها حاجه.
طبعا تنخضين صراحه.
هاي
ما عندي صراحه ريزن، بس I promise you to read about it and we can discuss إن شاء الله.
ما هو انا كانت النقطه بقى ان انا مش عارفه يعني المفروض في مور ايفالويشن انفستيجيشن، يعني اول مره وما كانش يعني كان 3.9 بعدين صار لو بعدين رد هاي تاني.
ايه ففي هالحاله دكتوره يعني هذا يخلينا شنو نسوي؟ يعطينا يعني بس مثل that if we are having a patient with hypoglycemia وعطيناه التريتمنت for hypoglycemia again the importance of the 15 minutes rechecking. فانتوا لما سويتوا مره ثانيه وشفتوا 1.5 او 1 something شنو سويتوا مره ثانيه بعدها؟
انا ما سويت شيء.
اعطيتوها
لا ما عطيتهاش حاجه، انا بس حطيت اوبزرفيشن كده، وكانت يعني ما فيش اي سيمبتومز طرقت على البنت قاعده كويسه. بس 15 minutes اجين يعني بقى اباف فاكره الرقم بالظبط.
خليتوها كذي بعد من ال 1 point something خليتوها تنطرون بس ما سويتوا شيء ثاني.
بس لأنها كانت شربت الجوس
I would give her another shot of any product يعني juice or something while keep an eye on her for more 15 minutes and recheck it again واعطيها advice على الكومبلكس كربوهيدرات. اصلا خليها تشتري ساندويتش او شيء نعطيها اياه وهي عندنا. And I would do insulin level for this patient and if it is high if it is like بشوف high ولا low كذي انا refer.
هو عشان ما كانتش ريكورنت يعني كهيستوري ما شكتش قوي في الانسولينوما يعني.
يعني الحين special diagnosis الانسولينوما البارياتريك سيرجريز والستارفيشن برولونج ستارفيشن ونشوف بنفكر بالاسباب الثانيه ان شاء الله.
اوكي شكرا.
هيا عشان اوكي I think ان شاء الله يعني ما في سؤال. في حال عندكم اي سؤال انا ready to answer all your questions you can send me a direct message على اسئلتكم كلها باذن الله. وبس وان شاء الله راح نقرا عن موضوع الهايبوغلايسيميا النون دايابيتيك بيشنتس ان شاء الله.
اوكي دكتورة سارة يعطيك العافية. see you next week ان شاء الله. ماشي حبيبتي، تصبحي على خير.